Cindy Gilbert.
My name is Cindy Gilbert, and I retired last year from Mayo as a physician assistant practicing urgent care medicine for 19 years. I still follow medical things very closely, and a number of the things that showed up in this bill caused me a great amount of concern. What I'm going to look at is from the business end of things and the clinician end of things. The House of Representatives and Senate bills both increase the risk of financial loss delivering health care to rural communities. 3 different healthcare organizations told this community some of the pitfalls of trying to provide primary care here. One of them was the fact that we are heavy on Medicaid and Medicare reimbursement, and the other one was recruitment of clinicians and also of nursing staff. Mayo told us this when they moved services from here to Austin. Mercy One told us this when they pulled out. Ironically, they're owned by a $19 billion medical corporation called Trinity, who was not willing to absorb the losses of doing primary care here. And United Health District didn't even get started for many of the same reasons. So that makes me worried, okay, when they're doing something that's going to increase the financial risk of providing this basic care here. On June 12th, 4 U.S. senators sent a letter to the Speaker of the House, the Senate Majority Leader, and the President detailing information about 338 rural hospitals that are uniquely at risk of financial distress, possible closure, and service reductions because of the cuts in the House bill. 2 of them were in Minnesota, so of course I scrambled to download the list so I could take a look at it. And one of them is in this congressional district close by. It wasn't Austin, but it was enough to really raise my eyebrows, thinking this is a little close to home. And now the Senate bill has even more drastic cuts and more hospitals are at risk. Senator Klobuchar was actually on national news today talking about that number's probably doubled and what the risk is to rural communities. Part of our legislative strategy here in Minnesota, if you were following along at the end of the legislature passing everything, is they were going to apply for a directed payment program to help boost our federal payments. But the amount of time to do it was short, and they had to get the application in. But in the meantime, the House version of the budget prohibits these new programs, and now the Senate bill looks like it will have cuts, making it less of a solution to help increase our Medicaid reimbursement in this state. Also, the workload of primary care clinicians cannot absorb the new technical provisions. There is a lot of new technical things in this bill that requires providers to do more frequent Medicaid eligibility reviews, more documentation with additional hours of paperwork, and this reduces the availability of care appointments for other patients. Never mind, the rest of the workload that they have to deal with. Many healthcare providers responded to a request by senators on the Health Committee to answer questions about what this would do if they had to do more work to make people get their benefits. So family medicine doctors and pediatricians are the lowest paid medical specialties. The reimbursement is lower for the care they deliver, and the margins are substantially smaller. Even private payers do not pay the entire cost of care. It was interesting that I went on to the medical systems, it's called Transparency in Clinical Charges, to look at the differences throughout the state of what a basic office visit is and who pays what. And even private insurance doesn't cover the cost of the clinic visit. And then you add in Medicare being less, and Medicaid even less, and Medicare Advantage less than that. So already, systems are not doing well in the primary care world, having any financial gain from any of this. But the other thing is the administrative burden of providing care is already extremely high and an extreme job dissatisfier. It's really hard to recruit people into pediatrics and family medicine. The days are long, the workload is large. They estimate that you spend 40% of your time in front of the patient and 60% of the time doing the administrative burden. We have a joke in medicine that's called pajama time. It's the 1 to 2 hours every night that people spend taking care of the work they didn't get done at the clinic during the day. Because they put their kids to bed, they put their pajamas on, and then they start finishing up. And so, the irony of all this is in this state, 78% of Medicaid adults are already working. 47% full-time and 31% part-time. So really, where is the gain if they're already working of, looking at their eligibility? So it's a dismal situation when people are uninsured. They wait until it's a crisis, And then the problem is a lot more expensive, not only to them personally, but also to the healthcare system, as these are write-offs things. And so I guess that's my question back, is what happens? What happens to rural healthcare? We already know that we have trouble here. People are hanging on, but still, it's like, what happens if it's still not enough here? It's like, where do people get care?
Thank you very much.